Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Today, we're discussing juvenile dermatomyositis, also known as JDM. My guest is Dr. Brian Feldman, a global authority on myositis. He will tell us why a simple $10 pocket magnifier can reveal nail fold capillary changes that are almost 100% sensitive for JDM diagnosis. He'll discuss how the mantra, treat the patient, not the antibody, shapes his management philosophy. And we'll also talk about what happens when this skin and muscle disease suddenly threatens the lungs, turning it into a rapidly progressive interstitial lung disease. From pathophysiology and imaging pearls to aggressive upfront therapy and future-looking interventions like JAK inhibitors and CAR T cells, this conversation has something for pediatric and adult providers alike. Dr. Feldman is Professor of Pediatrics, Faculty of Medicine, and Institute of Health Policy Management and Evaluation at the Dalla Lana School of Public Health in the University of Toronto. He's Division Head of Rheumatology at the Hospital for Sick Children. Dr. Feldman graduated from the University of Western Ontario and pursued graduate training in clinical epidemiology at the University of Toronto. He interned at the Mount Sinai Hospital in Toronto and went on to do a pediatric residency at the Children's Hospital of Eastern Ontario. Dr. Feldman returned to Toronto to be Associate Chief Resident at the Hospital for Sick Children and stayed there to complete a fellowship in pediatric rheumatology. Dr. Feldman's main focus has been in clinical research in the field of childhood rheumatic diseases. Among many successes, Dr. Feldman has made contributions to the understanding of the prognosis and treatment of juvenile dermatomyositis. His research is highly collaborative, and he works with several national and international organizations to advance the care of children with rheumatic disease. Enjoy. Brian, welcome to the show.
Hi, John. Thanks for having me.
So we're going to be talking about juvenile dermatomyositis today, and certainly there's some aspects of JDM that also apply for adult rheumatologists. So if you're an adult rheumatologist out there, I think a lot of the topics and information we're going to be discussing is going to be applicable to your patients as well. But, let's start focusing on JDM first. You see a lot of these patients in clinic. How do they typically present? What's the main complaint that, children and their parents have that eventually bring them to the rheumatologist's office?
So the kids that I see, by and large, present either with a skin presentation first or a muscle presentation first. By the time they make it to me, often the children have both. If it's muscle and the children are very young, it's often things like needing to be picked up. Most of the children are not so severely weak that they can't get out of bed, but some of the younger kids, it's just more frequent falls or needing to be picked up, getting tired more easily. The skin presentation usually goes to a family doctor or dermatologist first, sometimes misdiagnosed as psoriasis for a while, but many dermatologists can recognize it as fairly pathognomonic and send the patients on to me.
Great. And any specific things you look for in the exam to try to sort of confirm your suspicion or diagnosis of JDM?
So one of the things that we found is the most important clinical feature that marks the condition as JDM is the presence of nail fold capillary changes, which are easily seen with an otoscope if you want to. But I've got a cheap $10 magnifier with a light on it from Amazon that with a little bit of water-soluble gel like Muco or something on the nail fold, brings out the nails beautifully, as good as with my fancy digital microscope. So, the presence of nail fold capillary changes really gets at the pathophysiology of what's happening in dermatomyositis. That's true for adults as well, and it's close to 100% sensitive. So if I don't see those changes, especially if I have a child that's presenting to me without a very typical rash, that's when I start to really consider a broader differential diagnosis.
Super interesting. You talked about adult dermatomyositis. Is it the same disease presenting in people of different ages, or is there a different pathophysiology to adult dermatomyositis versus JDM?
Likely the pathophysiology between adult and juvenile dermatomyositis is identical for most patients. The treatments are probably going to be the same for both types of patients. There's probably differences in some of the clinical features. At least most series would suggest that some of the autoantibody profiles and clinical features do differ a bit between adult onset presentation and childhood. And then there's that large proportion of adult patients who have it presumably as a paraneoplastic phenomenon with cancer. And we don't see that in children. There's very, very fleetingly few cases reported of an association of cancer and dermatomyositis in children. So those would be the big differences. And, it's not surprising as we get older, we have so many comorbidities, the presentation will be a little bit different.
Yeah, it's, I've seen both children and adults with dermatomyositis, and I agree. I think, how they present, how they come to the clinic is a little bit different. And also looking for malignancy is something that we really focus on in the adult world, whereas it doesn't seem to be as present in children. So let's say you have a patient that, maybe have some weakness on exam, perhaps Gauthron's papules or abnormal nail bed capillaries, as you mentioned. What's your initial workup for those patients? What sort of labs are you trying to send? Any imaging or additional diagnostics?
So it probably is a little bit different at a center like mine. And the reason is that we contribute data to a number of different registries and follow the consensus-derived optimal data set that Dr. McCann and the group developed, which is a lot of information. So my patients get everything that's described, with the exception of a very typical case. We don't tend to do muscle biopsies. Now, there is potentially some prognostic information in muscle biopsies that's been shown. And if I had an easier way of doing muscle biopsies, for example, if at my center we could easily do needle biopsies, I probably would, even for children. Again, because it's a very academic center and we contribute data to so many registries. But what's necessary in a patient who's weak and has a typical rash is nothing else, basically. If they have nail fold capillary changes, that's pathognomonic. Like they have dermatomyositis, they may have some overlap condition. So muscle enzymes, EMGs, MRIs, things like that are useful for documenting and being sure you're going down the right path, but they're not really necessary. And that's why we stopped doing muscle biopsy in these kids with a typical rash. The myositis specific and myositis associated autoantibodies are nowadays being widely ordered for patients like this across resource-rich countries. They do vary a little bit in terms of the technicalities. The techniques used will differ in terms of the sensitivities and specificities. So the lab that's available to you might not look the same as in the literature, but they do tend to be very specific, meaning if you have a myositis-specific autoantibody, we're probably not dealing with some other mimic or condition.
Got it. And you mentioned imaging studies. I guess, do all of your patients get MRIs?
Yeah, so we have a total body MRI protocol, a whole body MRI protocol that we have at our hospital in Toronto. And every patient at onset gets that. And in very difficult cases, we'll do that again in follow-up if we're trying to see exactly what's the cause of, for example, persistent weakness or fatigue.
So what are the typical findings on whole body MRI that you find?
So it's really what we're looking for is edema in the muscle tissues and in the fascia. So that's best seen on fat-suppressed T2 images, things like STIR images. We're looking for the extent and the nature of those lesions. There's some suggestion, although not confirmed in every study, that if you see inflammation or edema in the fascia, that might be a precursor to calcinosis, which is something we see more often in children as a consequence of dermatomyositis than is reported in adults.
And, for people that, I don't think in my center we can easily get a whole body MRI looking for myositis. We typically think about sort of like a thigh, bilateral thighs. Is that sort of, the recommended approach, or what would you suggest in the absence of whole body MRI?
The money is in the proximal musculature. So if you could do a shoulder girdle and hip girdle or one or the other, you're probably going to find edema in a case of dermatomyositis.
And one of the things we want to focus on is the MDA5 variant of dermatomyositis, which presents again both in children and adults. It's one of these myositis-specific antibodies that has a sort of interesting clinical correlate. Can you talk a little bit more about sort of clinically how MDA5 is different, or it's a different subset than other types of JDM?
I think one of the things that is probably most important is in my practice and the way I think about it is you have to treat the patient and not the antibody. And if we look, for example, there was a small study reported in Rheumatology International that compared adults with anti-MDA5 to children with anti-MDA5. And that's a small study. Some of the things that we typically associate with so-called anti-MDA5 dermatomyositis were seen less often in children. So in that series, for example, there was no interstitial lung disease, no rapidly progressive interstitial lung disease, no chronic interstitial lung disease. There were some patients, like about a quarter of the patients had amyopathic dermatomyositis or clinically amyopathic, typically something we think about in adults with anti-MDA5. About half the patients had ulcers, cutaneous ulceration. Arthritis was seen in about half the patients. Gulnara Mamarova at the NIH and the group there looked at a larger series, about, I think it was 35 or something like under 40 children with anti-MDA5. And the biggest correlates when compared to other autoantibody positive patients were with the presence of arthritis and weight loss, it seems like. So some of the things I think that we think about in terms of typical anti-MDA5 are maybe less often seen in children. There is a nice German study looking at their registry and looking at their patients. So anti-MDA5, they saw in about 6% of their patients. That's pretty typical. I think if you look across the world, except in Japan, maybe in China, where they have more, most of us see only about 1 in 20 of our patients will have anti-MDA5. In those patients, if you do the calculations, which I did because I'm interested, about 5% of my patients have interstitial lung disease just off the board, if I don't know anything. The likelihood ratio for positive test in that German registry was about 10. That means that risk goes from 5% to 34%. Now, so that's important potentially to know about, but it's still only 34%. That means that 2/3 of the patients with anti-MDA5 will never have interstitial lung disease. I think it works the other way around. If you have rapidly progressive interstitial lung disease, which is a terrible disease, often fatal, usually within the first few months, almost always within the first 6 months of presentation, you will have an anti-MDA5 antibody. So it's highly associated with that condition, but that condition is so rare. We've had 2 cases in Toronto, both fatal, and that's over, my tenure there is about almost 40 years. And that's out of hundreds of children with dermatomyositis. So it's a very rare presentation. In both cases, the patients died before we had the antibody back.
As it typically happens with these patients that are very sick in the ICU.
So if I get a patient and the antibody test shows it's anti-MDA5, I don't do anything different. I just watch the patient and see what happens. And if they get interstitial lung disease, we treat it. And if they don't.
So do you screen for them? Do you get a, high-res CT?
I don't, just on the basis of having anti-MDA5. I think if symptomatic is much more important. I'm not sure what I would do if I had a little bit of, say, ground glass appearance on a CT scan. Is that worth upping therapy to the degree that's necessary without any correlates? But many people do. So that's just my current practice, is not to react to any of the autoantibodies, with the exception of the patients who have immune-mediated necrotizing myositis. So in pediatrics, that makes up just about everybody we used to call polymyositis, because we don't have inclusion body myositis and things like that. And those patients, that's 100% in my practice. If you have an anti-SRP or anti-HMGCR, they've got that condition, and we treat them a little bit differently.
Interesting. Do you have any sense of what these antibodies are doing? Are they sort of hanging out, or are they actually contributing to the disease, the myositis-specific antibodies?
I mean, it would be nice if we knew, and we don't. And there's all kinds of speculations that they might be somehow pathogenic. I mean, anti-MDA5 itself, it's very tempting, right? So the melanoma differentiated associated gene 5 protein, right, is a receptor in the cell cytosol that is specifically recognizes long double-stranded RNA that's usually viral and turns on type 1 interferons. And that's, of course, what we consider now to be one of the driving immunopathologic features of dermatomyositis and lupus and everything else. But that high type 1 interferon signature, we've shown it, many people have shown it, is a strong correlate of disease activity. So it's very tempting to think that somehow or other that protein is involved, and whether the antibodies themselves are just reacting to that protein somehow being exposed as a neoantigen, or if they're actually pathologic, I guess we'll figure that out.
Very interesting. You mentioned before about sort of the nail bed capillary changes, how they are sort of pathognomonic. Can you talk a little bit more about how they sort of explain what's going on in the muscle?
Yeah, so I suppose I wouldn't say nail fold changes are pathognomonic as opposed to the rash, which is pathognomonic, because of course we see nail fold changes in Raynaud's, and we see it in scleroderma and in overlap conditions and mixed connective tissue disease. But they're always present. They're very sensitive. And along with that pathognomonic rash, to me, make the diagnosis. And maybe I'm oversimplifying this, but the whole pathology and pathophysiological process in children with dermatomyositis seems to be a vicious circle between an immune situation that looks like a chronic viral infection, like a lot of interferon, type 1 interferons especially being triggered, mitochondrial damage, and there's some back and forth between damaged mitochondria and interferon, one causing the other, and capillary damage. And capillary damage is often, we see complement in the wall of the capillaries, endothelial destruction and obliteration of capillaries. And that leads to muscle ischemia and ischemia of other tissues, which leads to more mitochondrial damage, which leads to more type 1 interferon production, which leads to more capillary damage. And this is some kind of vicious circle that it's unknown why, but in many children just seems to go away over time. So we have about a third in my clinic of children have a monophasic disease, meaning after about 2 or 3 years, they're off treatment for the rest of their lives with no relapse. And another third, after about 7 years, they go into complete remission. And when I talk to my adult follow-up colleagues, many of the adults I send to them with active disease eventually go into remission. That's not really like lupus or rheumatoid arthritis or things that tend to, if they go away, they come back.
So are there any specific triggers? Like you mentioned, it looks like a virus. Are there known triggers for JDM?
So we can give a lot of thanks to groups around the world that have tried to study this. It's clearly very difficult. Sunlight exposure seems to trigger not just flares, but might be associated environmentally with the onset of the disease. And we know that, for example, in lupus, that sunlight in the skin can trigger the surface expression of what otherwise would be hidden antigens. So maybe that's a mechanism. Other types of environmental exposures have been less consistently associated with the development of dermatomyositis, but groups in Brazil, the NIEHS at the NIH, groups in China have looked at environmental factors without really us coming up with a virus that causes this.
And so what's your sort of initial approach for treating these patients that you see in clinic? Let's say they have the Gottron's papules, the capillary changes, elevated muscle enzymes. What's next?
We've known since since publications in the 80s, but I guess since the 70s, that corticosteroids work very well in this condition, prevent to a degree calcinosis, and save lives. So corticosteroids are the primary treatment. And when I started, that were the only treatment we were using as a first-line treatment. But after so many of my patients came in with insufficiency fractures and cataracts and diabetes, I started in the mid-1990s treating everybody with methotrexate up front. And I think shortly after our publication, or maybe at the same time, but without publishing, other groups started to do similar kinds of things, treating with steroid-sparing agents right from the beginning. And because of that, the group in Europe, the Printo group, did a randomized controlled trial comparing prednisone alone to prednisone plus methotrexate, the approach that we had promoted, and prednisone and cyclosporin, which was often being used in Europe. And the prednisone and methotrexate, just lucky guess on our part, turned out to be the superior treatment in terms of efficacy and side effects. So I think just around the world, everybody does that. Lauren Pochman and the group in Chicago promoted the use in most patients of very high-dose pulse intravenous methylprednisolone at the beginning. Many people do that. I often don't on a moderate patient because I treat all my patients as outpatients. If they're sick enough that they have to be admitted, meaning they can't swallow and they're not safe to go home, things like that, then we might use pulse intravenous at the beginning. Many of my patients, and this is a bit of a feature of the Canadian healthcare system because it's free for them, are treated shortly after onset if they're more severe or a little bit later if they're a bit resistant with intravenous immunoglobulin. And we published a lot about that. And now, of course, there's the big in adults Octagam study that showed that it's efficacious. And more, it's not first line for us, but it's being studied in 2 studies in children in Europe, one in England and one in France. We're using JAK inhibitors. And that might become a first line treatment for many patients, but pathophysiologically makes sense. The anti-type 1 interferon monoclonal antibodies like anifrolumab have been used now in a few cases of really resistant disease. And one wonders if that might not be a good therapy in the future. And then CAR T cells, right now they're mostly anti-B cell CAR T cells, anti-B cell markers, but there's also anti-NK cells that are going to be studied in this condition, CAR T NK cell directed therapy. Once you can get those that don't have to be custom made and they can be off the shelf, maybe that's a cure and just everybody would go get that right at the beginning.
The world to come. I'm amazed by all those CAR T cell studies that they're very, very provocative. Talk a little bit, Brian, about sort of the typical prednisone dosing that you use and the length of treatment of prednisone.
So we probably in our clinic in Toronto use a shorter and a smaller total cumulative dose of prednisone than most people based on the published guidelines. So I start all my patients on 2 milligrams per kilogram per day. And I might go up a little higher than many lupus patients would go to 80 or 100 milligrams, depending on the size of the child, not above that, and divide that into usually 3 times a day for about 6 weeks. And if I see a response, then we'll consolidate to twice a day and then to once a day 2 weeks later. And then I drop by 5 milligrams every 2 weeks. When we get to 25 milligrams, we drop by 2.5 milligrams. That's just because the prednisone pills are 5 milligram size. Do that every 2 weeks so that the average time that someone's on prednisone is about 10 months. And I try to never go back on corticosteroids if I can with patients, sometimes impossible, but mostly doable. And I'll add in other agents once there's a nice background of methotrexate plus or minus intravenous immunoglobulin.
And for the methotrexate, do you start oral or do you just go straight to subcutaneous?
So, I'm elderly, as we say. And so I had started using oral methotrexate way back when, using a dose about 15 milligrams per meter squared to begin with. And it worked fine. And then there was a kind of a worldwide consensus that we should switch to subcutaneous. So I did for a while. I'm dealing with children. They don't like needles. And it was no better. And there was no less toxicity, no fewer patients who were finding that they were throwing up. And so I've switched back to oral in almost all cases. And I'm probably maybe a little extreme in the sense that if children are starting to get nauseous or vomiting, I don't try and manipulate the methotrexate at all. I just switch right to another agent. If it's working, I'll go to leflunomide because that seems to maintain patients well if they're on methotrexate but vomiting. And if it's not working, I'll go to mycophenolate mofetil or a JAK inhibitor or something like that.
Got it. And when do you think about adding IVIG to these patients? Or do you do it for all of them or just a subset?
No, not for all of them. If they're very severe weakness at the beginning, very severe means you can't get out of bed. If they're very severe weakness, then I'll start at the beginning. I throw everything at them at the beginning. And then the other group and the biggest group are ones who have resistant skin rash. They get strong, they're doing well, but the skin rash persists. And we've shown that that's a bad prognostic mark in the future. I don't know that fixing it makes anything better, but it's something I'd like to get rid of skin rash. try and avoid, in my mind, calcinosis developing. And so those patients will start on IVIG rather than bumping up the prednisone.
Yeah, I always wonder, and I think in pediatrics, we always have a sense that, as you mentioned, most patients, recover from JDM and eventually achieve remission, drug-free remission, which in the adult world may not happen as frequently. And I wonder if it's partly because we treat patients much more aggressively upfront with a lot of steroids that we typically don't do as much in adult patients. What do you think?
I think there's enough difference in being like as an adult now, I know I don't recover from anything. So I think there's enough difference just in terms of the healing abilities and the plasticity of young children that it would be really hard to ascribe why it's different,
Mm.
any change in practice. The corticosteroid doses that I'm using in these kids are pretty typically done all over the world, something like that.
For children, I agree.
Yeah, of course, for children, although many people will have a much longer taper than we do. So the children tolerate it well. I mean, we showed when we started to do that we weren't getting cataracts anymore. We weren't getting insufficiency fractures. Growth caught up well. Like there wasn't growth disturbance the way there was before. Again, that's not something we worry about for adults. But also, I don't keep them on 5 milligrams forever the way you might with an adult. So the approach is quite different. I just don't know if that makes a difference in the end.
Let's talk just a little bit about the rapidly progressive ILD, which, is sort of a very catastrophic presentation of this disease. And I still don't understand, why some patients get it. We're talking about a muscle and skin disease, and some patients have very exuberant inflammation around the lungs. Can you talk a little bit about sort of, the rapidly progressive ILD that we see sometimes associated with this disease and why it happens in some patients?
I wish I could talk in a cogent and intelligent way about it, but this is a very rare disease. There's handfuls of case reports in children. I had Tomo Nozawa is a rheumatologist and a pediatric rheumatologist in Yokohama, and he spent a couple of years with us in our clinic and our program. And apparently this happens much more frequently in Japan. And the anti-MDA5 is the dominant autoantibody that they see. That I think the Chinese have published a fair bit about this. They probably know more about it. The best that I can say is that it seems to be worse. Interstitial lung disease in general seems to be worse if you also have Rho52, anti-Rho52. It presents early. A good proportion of the cases within 3 months of symptom onset and almost everybody within 6 months. The fatality rate is high. Treatment has to be aggressive. I go by the ACR guidelines, which are basically for adults with interstitial lung disease. That was Sindhu Johnson's work published a few years ago. And they have a kind of an algorithm for rapidly progressive ILD and MDA5 positive, which is at least 2 of, on top of steroids, rituximab, cyclophosphamide, IVIG, mycophenolate, a calcineurin inhibitor, and a JAK inhibitor. And most of the patients, and most people I talk to, had their patients on all of them because they're on ECMO and we can't get them off.
Yeah, it's a horrible disease, and hopefully in the future somebody will figure out, how to identify these patients early and more beneficial treatments. And I agree with you. I think part of the complications is that, as I've seen it, very, very sick patients in the ICU, and, that MDA5 is still pending. And by the time it comes back, it may be already too late. For most patients, thankfully, that don't have the rapidly progressive ILD, how do you sort of monitor them over time? How frequently do you bring them in clinic? And what's your approach to, the clinical exam and blood work?
So again, it probably differs in my clinic because we're following that international guidelines, and a lot of it is for data collection. May not be actually necessary for many of the patients. And I discuss this with the patients before, and so they know. But at the beginning, and again, I try and treat most patients as outpatients right from the beginning. And that would be, 90+% of the patients are treated as outpatients. So I see them every 2 weeks at the beginning for the first 2 or 3 months. And then we go monthly, and then 6 weekly. And then when they're really in a taper, they're off their prednisone, they're doing well, 3 monthly. and eventually 6 monthly. And when they're off medications, I follow them yearly until I transition them to the adult hospital. And we have a nice program with the adult myositis program here in Toronto for transition. Now, at that time, we're doing everything, right? So they're getting a physiotherapist who does all the scored clinical examinations. We're measuring their blood work, mostly muscle enzymes and other inflammatory blood work. They're getting a full clinical examination, getting nail fold capillaroscopy, like everything. And largely that's for data collection purposes. Most of these children really could be handled, I think, clinically with a virtual visit and just a check-in and saying, how are you doing? Because the treatments work so well in kids.
And what are the things that you would either see on exam or on labs that would give you pause and think about, do they need more steroids, higher doses of steroids, different medications? Is it the clinical exam? Is it the CK, aldolase, nail fold capillaries?
Yes, almost always those things run in concordance with each other. So it's almost always a history that tells me, rather than my brief exam, someone's got a month or 2 weeks of saying, getting tired, I'm not feeling as well, or my rash is acting up more. So that's usually sufficient. The really good markers, or they seem to be really good markers, for us are still only available as research tests. I think there's clinics around the world that are using interferon gene scores or Siglec-1 or galectin-9, CXCL10, things that are really markers of interferon activity and are very faithful measures of disease activity. But in my clinic, I can only have those as research tests and I can't act on them clinically. So I think in the future, we might be able to monitor patients very well as outpatients, just with one of those tests and, on a virtual visit and just say, you don't even have to come to clinic.
Amazing. And Brian, can you talk a little bit more about sort of the research that you're doing and other groups are doing to try to improve outcomes for children with JDM?
And one of the things about dealing with very rare diseases, and at any point, because my children age out at age 18, they move on, I'm only following about 70 patients with dermatomyositis at any point. And we have one of the largest clinics. We have the largest in Canada, one of the biggest in North America, one of the biggest in the world. So nobody has enough patients to do this by themselves. So all of the work, besides our little local studies, are collaborative work. And the big collaborative groups are the Pediatric European Rheumatology Society, the PRESS, JDM Working Party has a number of big groups. So we've just published treat to target principles. We're going to work putting in a grant. I'm not putting in the grant. I'm one of the people on the grant that's going to look at testing out the treat to target guidelines. There's lots of works that we've been doing with European folks about biomarkers. Basically, we're just contributing samples to those. There's all kinds of clinical work that's being done in North America by the Childhood Arthritis and Rheumatology Research Alliance. That's CARA. And we've contributed data to CARA since its inception. And a lot of projects are coming out of there. Right now, we're just in the process of doing a follow-up looking at comparative effectiveness of different treatment strategies using the CARA registry. Adam Huber is leading that study. And then locally, we've been largely interested in lifestyle changes. So we've just submitted a paper that has been presented that's looked at supplementation with creatine and coenzyme Q10, along with exercise, at those patients who are in a stable course of their disease, but still maybe not fully strong. And our results are positive, but I'm a little cautious about the results of that study. The paper hopefully will come out shortly and people can have a look at that. And those are the kinds of things that are going on internationally. And of course, as I said, there's 2 clinical trials now with JAK inhibitors. There's hopefully a CAR T-cell trial starting that will look at children with dermatomyositis. There's one in the United States, hopefully one that is international. There are studies looking at new agents in adults with juvenile dermatomyositis that aren't enrolling in children yet. So there's all kinds of stuff going on.
Super. You hinted at sort of supplements and exercise and other things that you're doing. Can you talk a little bit more about the non-pharmacological management of patients with JDM? What is it that you tell them to do and avoid in the clinic?
So what we do, and I think centers around the world that have access to this do, is we have all of our children, all of our patients involved with physiotherapists and exercise programs. All of them see dermatologists. We have collaborations with the dermatology group and get prescribed sunscreen, topical agents if necessary, and good skincare routines. I talk to families about diet. I'm very interested in it. We don't have enough patients with dermatomyositis to study diet and microbiome, but we're doing that now across Canada with children with arthritis. And so we talk about ways to maximize the health of the microbiome and dietary strategies. All of those things very, very important. But because it's a very rare disease, all of them need further study to really be confident and I think develop recommendations that everybody can feel comfortable with.
So yeah, a lot of, parents ask about exercise. Should my child exercise? When can they get back on the soccer field? What's your advice to parents?
So everything we've seen so far and all the studies that have been done show that exercise is safe in dermatomyositis and that's potentially helpful. And I say potentially because we have a bunch of small studies and we don't have conclusive randomized trials that show. But the muscles in motion study in particular show that there's a number of outcomes that are really getting improved with exercise. So I recommend to all my patients, as long as it's safe, go ahead and do it. Now, what's not safe? Well, if you're on a lot of corticosteroids, ski jumping is probably not safe. And American football or ice hockey with a lot of contact, probably not safe. Horse jumping, that's the thing that my patients hate the most when I tell them they can ride, but they can't jump. If they're horse enthusiasts, they hate that. But once they're off the corticosteroids and it's safe, they can do all of those things. Soccer is fine as long as you can stand. You're not going to fall and hurt yourself. So once there's a sufficient minimal amount of strength, we encourage exercise a lot.
Great. And Brian, one last question. Are there any questions that keep you up at night? Anything, you want to learn more about JDM?
I don't know for sure why I'm so interested in this condition and why I started this program so many years ago with encouragement from my senior colleagues. I do know that two of the first patients I saw when I was a pediatric resident and I was doing surgery early on were two teenage girls who came in for removal of calcinosis who had JDM. Wow. I would love to know what it is we can do to prevent calcinosis from developing, because we still see it in about a third of our patients, and how we can minimize the functional consequences, and we reduce the symptoms of it, prevent it, and potentially eventually treat it. And, after all these years, I still don't have a clue.
Very good. Brian, this has been a really awesome conversation about JDM and, dermatomyositis in general. We covered a lot, including sort of the pathophysiology, the clinical presentation, monitoring, management. It's been really great and would love to have you back sometime. Maybe, after there's been some trials about JAK inhibitors and other, CAR T cells and other interventions for these patients. But thank you so much for your time.
Thank you, John. It was a pleasure.
Wow, that was a masterclass on juvenile dermatomyositis with Dr. Feldman. We learned that a careful look at the nail folds can clinch the diagnosis of JDM, that most children enter remission, even if it sometimes takes years, and that MDA5 is a useful clue, but not a sealed fate, given that only a minority will ever experience rapidly progressive ILD. Most importantly, we were reminded to keep our focus firmly on the patient in front of us and not just the lab reports. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep treating the patient, not just the antibody. And of course, stay healthy.